Our next topic, my colleagues, is Professor Dave Singh, who's going to speak to us on mortality benefit in COPD. Before his speech, I'd like to introduce to you Professor Dave Singh. He is a professor of clinical pharmacology. Yes, he's a clinical pharmacologist and respiratory medicine. So he wears more than one hat. That's why I would tell you that his influence on me when he speaks on the topics of respiratory medicine in general is like a magician. He can convince you anything he wants. And I hope that this will be your impression by the end of his talk. He is a professor of clinical pharmacology and respiratory medicine at the University of Manchester. He is specialized in clinical pharmacology and respiratory medicine, and his interest is in the development of new drugs for asthma and COPD. He's the principal investigator of over 300 clinical trials. That's a lot. I hope that I can get even closer to 1/4 of this. Professor Singh today is going to speak to us about a topic that has not been visited frequently, to be honest with you, until the last couple of years. Mortality benefit really in COPD, Professor Singh? Please talk to us about that. Thank you.
Thank you, and great to see you, Ashraf, and thank you for the very nice introduction. I would like to say that there's one difference between me and a magician, and that is magicians play tricks, and everything I'm going to say is actually true. So
I agree with that.
Sorry for the delay. So I'm going to speak on mortality benefit in COPD, and as you just heard, this is something that we have not had the chance to talk about because there's been very little conclusive evidence that any pharmacological therapy would reduce mortality. But now we have that evidence, and that evidence is with triple therapy in COPD. So I'll say at the outset my view that this evidence is absolutely clear, and I'll show you this from two very large studies. There are some voices that would doubt this, and we'll discuss that as we go through the presentation, why you might doubt this. So before we start, I just show you briefly my disclosure of interest. So the learning objectives today. At the end of my presentation, I hope you'd be able to describe the triple therapy effects in the large COPD randomized controlled trials, and you saw some of this in the previous presentation, on exacerbations and mortality, because there is a link. So I think you need to see both of them at once. And then the key question is, how would you apply that information to your real life practice? Does it help you? So I'm focusing on triple therapy, and I'll start by just showing you where triple therapy fits in gold. This is the follow-up algorithm. Some people say, well, this looks a bit complicated. Actually, I would say that all it says is that you escalate from single to double to triple. And I think you would do that in your clinical practice anyway. The only complexity really is when to use inhaled corticosteroids. That's the question. And for that, for patients with exacerbations, we use the level of the exacerbation history and their blood eosinophil count. So you know during follow-up that patients may have predominantly dyspnea, that's the problem, and then you follow that algorithm, or do exacerbations need treating? Then you follow the red algorithm. And triple therapy for exacerbations is a step up from a double combination therapy. So let's look at the evidence base for this recommendation that triple therapy would be a step up from double combinations. Well, there are plenty of studies that provide supporting data. And again, in the previous presentation by Paul Jones, you saw some of that. I'm going to focus on two studies, the impact and the ethos studies, because these are where the strongest data on mortality comes from. I'll show you the exacerbation and the mortality data. There's something unique about the populations of impact and ethos. There's a very high rate of exacerbations in the previous year in both populations. Let's have a look here at impact. There's 10,000 patients in this study. It's enormous. We have 70% of the population had 2 exacerbations in the last year or a hospitalization. And in fact, 1/4 had a hospitalization. So if you look historically at randomized controlled trials, by exacerbation history, this is a very high risk population. The fact the study is so big also gives you a lot of statistical power to look at all the endpoints. And remember, exacerbations was a primary endpoint, but we'll come to mortality. It was a pre-specified endpoint. And I want to stress that it's not a post-hoc analysis, it is pre-specified. So we have a high-risk population. Have a quick look at the previous medication the patients were on. Nearly 40% were on triple therapy, 30% were on ICS/LABA. So in this high-risk population, we have a lot of patients using ICS. And you would expect that because ICS are recommended for people with exacerbations. So when we look at hospitalizations, so here I'm just focusing on the severe exacerbations, triple therapy was the best treatment. And actually there was 34% less exacerbations, severe ones, compared to dual bronchodilator. If we look at moderate, and moderate are those in the community, oral steroids, antibiotics or both, moderate and severe, that difference was 25%. And these are both statistically significant. So let's look at the ethos study. The ethos, again, a very large study. We have 8,000 patients. There's a different triple therapy. And in my lecture, I'm going to treat these all as a class because I think we're seeing class effects here. We're seeing class effects on exacerbations and we're seeing class effects on mortality. So I'm going to show you here moderate and severe exacerbations combined. Triple therapy versus dual bronchodilator is a 24% advantage. That's the ICS effect. Remember, in the impact study, it was 25%. Highly similar, and that's why I'm calling it a class effect. In both of these, the effect versus ICS/LABA, the benefit of triple therapy was significant, but ICS/LABA seemed to be a sort of intermediate treatment. So the best treatment was triple, the next best was ICS/LABA, and then the least effective was dual bronchodilator. So just rounding off exacerbations, the benefit of ICS-containing combinations was better at higher blood eosinophil counts. There's an awful lot of data that looks like this. What you see here is that at around 100 eosinophils per microliter, depending on how your lab expresses it, it could be 0.1. 100 is the number. Below this, there's not much effect, or actually you could say inhaled corticosteroids don't work. Above this is where you see the ICS benefit. And as the eosinophil count goes up, the effect gets bigger and bigger. Now, I just want to spend 30 seconds on eosinophils because it's a controversial topic, and then we will get to mortality. Some people worry that there isn't a strict cutoff with eosinophils. I'm saying to you that as blood eosinophils, as the count increases, the effect gets bigger. And that's because the benefit of pharmacological treatment varies hugely between individuals. any drug you use. Some patients will have no benefit, some patients a small benefit, some patients a big benefit. There's a spectrum. So this is a pharmacological biomarker. It's predicting beautifully that spectrum of benefit. So at 100, you could say below this, there's not much benefit. Between 100 and 300, there is a benefit, and above 300, the benefit's really quite large. There will never be a single threshold. And actually, in GOLD, we talk about 100 and 300, and these are just estimations, they're approximations. You shouldn't regard them as strict thresholds, where below this, you make one choice, and above this, you make another choice. They're just approximations. So the patient who has a blood eosinophil count of 90 one day and 110 the next, it's the same patient, they're down the bottom end. So let's move on to mortality. I'll come to this later, but we know that there's a link between exacerbations and hospitalizations and mortality. You know that from your clinical practice. I don't need to show you any research. You know from your clinical practice that sick patients who enter hospital, some of them die. And if you can prevent those events, you may have a chance of reducing mortality. This is all-cause mortality in the IMPACT study. I'm now going to focus on triple versus dual bronchodilator. The original on-treatment all-cause mortality is the data in the New England Journal of Medicine paper. When we then include patients who discontinued, that is then the blue line in the middle, including off treatment, we can then go and retrieve data from patients who were lost to follow-up. That's additional vital status. Different ways of looking at it, it doesn't matter. All statistically significant, and a benefit on mortality ranging from 28% up to 42%. This is a pre-specified endpoint, not a primary endpoint. The purists would say that to definitively prove an effect on mortality, you need a primary endpoint study. And actually the regulators, the drug regulators also generally take that view. That doesn't negate the value of these findings. These findings are real from a pre-specified analysis. And actually the findings become more and more real when you see something that's almost identical in a second study that has a similar design and is basically just as big, the ETHOS study. When you look at the final retrieved data for all-cause mortality, there's a 49% reduction for this triple therapy versus dual bronchodilator. And I think that's fascinating. We're seeing, as pre-specified endpoints, we're seeing these reductions in mortality in 2 replicate studies. Now, the number needed to treat here then versus dual bronchodilator in 1 year is 80. 80 patients with this exacerbation risk will save you 1 life. And that compares very favorably to other medicines that we use in clinical practice. Eosinophils, I think this is fascinating. There are people who doubt whether eosinophils are valuable in clinical practice. They're a very straightforward test, very simple to interpret. Below 100, triple therapy probably won't work. Above 100, it probably will work. Above 300, the patient will probably get a big benefit. That's in terms of exacerbations. Now look at this graph from the ETHOS study. It seems to be true for mortality as well. The mortality benefit for triple therapy is related to the eosinophil count. So I want to deal with some of the controversies now. For those of you who read the literature, go to congresses, you'll hear some debate about the fact that, well, these studies, IMPACT and ETHOS, there was inhaled corticosteroid withdrawal Surely this benefit on exacerbations and mortality is all about ICS withdrawal. Well, I have 2 points to make, and these are both common sense. First of all, even if that argument was true, that these benefits are all due to ICS withdrawal, it basically proves the point that ICS is giving you the benefit. Whether it's ICS addition or taking it away, if you see a signal on mortality or a signal on exacerbations, it's proving the benefit of ICS. Now, the second point to make is actually that patients in these high-risk studies, in real life, the use of ICS is connected to a higher exacerbation rate. So look at the numbers on this figure. The patients on triple therapy, look at the on-treatment exacerbation rate for triple therapy, 1.22. The on-treatment, I mean during the study, for dual bronchodilator, 1.76. Now compare that to all the other groups. So those patients I've just described, they were on triple therapy in real life. And then during the course of the study, whatever they received, they carried on having the highest rate of exacerbations. Now that's fascinating, I think. And what's it telling you? It's telling you that doctors in real life have found these patients. They're really sick, they're having lots of exacerbations, and they're giving them triple therapy. Now you want those patients to receive triple therapy, and what we're proving is if you randomize them to dual bronchodilator, they do a lot worse. It means they need triple therapy. Now there's still room for improvement, and that's where the future of pharmacological therapy hopefully will evolve with new chemical entities. So when you look at the other treatments, the sample size gets lower. That's the first thing to note. So for ICS LABA, you're down to a lower sample size. And then when you go to LAMA alone, that's actually a very small group. So the confidence intervals get wider. Interestingly, the treatment benefit of triple therapy also goes down. So I think this is beautiful data for telling you who triple therapy will work in. When you go to the bottom, the LAMA, people in real life receiving LAMA, they have the lowest rate of exacerbations. And probably you don't need to jump straight to triple therapy. But for those patients on double combinations, you can see the benefit of triple therapy. Now, I wouldn't worry, this is a post hoc analysis. I would not worry about the size of the confidence intervals. In these post hoc analyses, I would focus on the point estimates. I haven't got time, but if I was to show you this graph for severe exacerbations, the confidence intervals get smaller. Now that's exacerbations, this is mortality, and it marries up. For those patients previously on ICS, and a lot of these are on triple, they're the sickest patients. If you randomize them in this study to non-ICS containing therapy, their mortality is higher. For those patients not on ICS, less sick, less exacerbations, there's no difference in the mortality signal. So there's this really interesting interplay between what the patients were like in real life, what doctors were giving them, and those patients on ICS in real life were sicker, and if they got randomized to a dual bronchodilator, they did worse. So it's an interplay between real life and what happens in clinical practice. So this simplicity saying, well, it's just ICS withdrawal, it may be ICS withdrawal, but it's got an implication for real life. Don't do it in these sick patients. And thinking about this ICS withdrawal, I'm going to switch to the ethos study. You've just been seeing impact. It doesn't really matter. It's a class effect. When you look at triple therapy versus dual bronchodilator, at exacerbations throughout the course of the study, you actually, when you remove data, if you were to see a surge in exacerbations in the first 30 days after withdrawing ICS, you'd then see that the treatments would be very similar later on. And we see here an analysis where you remove data. The first 30 days, the first 60 days, the first 90 days. There isn't any surge. The treatment benefit of triple therapy versus dual bronchodilator is maintained across the course of the study. So why is there this benefit? We're going to think mechanistically. Well, first of all, something very obvious. I said it earlier. Hospitalization. If you reduce hospitalization, you'll reduce mortality. Here's almost 100,000 patients in real life practice. The highest mortality is in those with hospitalizations. And the more exacerbations, the worse the mortality. Here's data from the IMPACT study. Those patients who died had more exacerbations. They had more moderate and severe exacerbations. They had more severe exacerbations. So there's definitely a link. But actually, interestingly, 42% of the patients who died did not have exacerbations. So there's something else going on as well. What is that something else? Well, we know that COPD patients have a lot of cardiovascular causes for mortality and cancer as well. So we expect that to happen. They have a lot of comorbidities. But there's an overlap between cardiovascular and respiratory causes. And we know that from other data. Patients experiencing exacerbations are more likely to have a cardiac event during the exacerbation. So here's patients admitted to the emergency room. A lot of them had ECG changes or cardiac enzyme changes or symptoms compatible with a myocardial event. And what we're seeing here then is some exacerbations provoke cardiac events. Eventually, the cause of death might be a myocardial infarction, but what happened first? The exacerbation. If you prevent those events, you can prevent cardiac death. So coming back to this controversy, in an ideal world, we would like to see a primary endpoint study that would say compare triple therapy versus dual bronchodilator. What we ended up with is two studies that are enormous, 8,000 and 10,000 patients. They have enough statistical power to demonstrate the superiority of triple therapy against dual bronchodilator. And as pre-specified endpoints, we're seeing almost identical data that there isn't a benefit in this patient population. That's key. In this high-risk population, there's a benefit of triple therapy. It is eosinophil dependent. The Goal 2021 update recognized this. Two high-quality studies, consistent data. There's a benefit on mortality. So I'll come back to the learning objectives. I hope now that you understand the data better. I'm sure many of you knew it very well anyway. I hope you were able to take something extra from my views. There's a connection between exacerbations and mortality. When you take clinical risk, exacerbation history, put it together with eosinophil count, you'll be able to apply that to your clinical practice and be able to use triple therapy in a personalized manner. So thank you for your attention. I hope we have time for questions now.
Thank you very much, Professor Singh. You know, these small booklets when you do your medicine and residency training called like Neurology Made Easy. To me, I like your session because it makes such a complicated topic made easy for me. So I thank you for that. And I'll try and summarize some of the points that you nicely outlined, Professor Singh. So Professor Singh was basically trying to convince us that triple therapy in patients with COPD who fulfill similar criteria to these two big trials can have less exacerbation, and we know that less exacerbation means less mortality, and these were pre-specified endpoints for the studies, and they were proven to show the results. Numbers like triple therapy having 24% reduction, as opposed to ICS LABA having something around 13 or 14% reduction. And in the other trial, triple therapy having up to 49% mortality reduction, as opposed to 28% for the ICS LABA. My question for you, Professor Singh, for me as a general pulmonologist, I know the impact study criteria for patients being enrolled in the triple therapy included somebody who 25% of them had an exacerbation leading to hospitalization. More than 2/3 of them, 70%, had 2 or more exacerbation per year. So tell me, please, what are the check marks that I should do that should alert me and red flag my chart? This is somebody who should be on triple therapy tomorrow as a COPD patient in the clinic.
Yeah, thank you. So very simple. Here's 3 points. 1, have they had a hospitalization in the last year? 2, have they had 2 exacerbations or more in the last year? 3, is the blood eosinophil count more than 100? So if they meet either 1 or 2, so that's the clinical criteria. They don't have to meet both, they can just meet one of them, the clinical criteria, and they meet the biomarker criteria, you give them triple therapy. That would be a very simple view.
So 2 of the 3, and they have to have 1 of the clinical criteria.
Yeah.
Perfect. Thank you. That's actually, again, made simple. And the eosinophil count being one of the criteria, as you may know, the eosinophil count sometimes can be inconsistent from different readings, visit to visit. How many readings shall we use in clinical practice to consider the eosinophil count significant? Is it variable?
Yeah. So if you'll allow me, I think there's a very important mechanistic concept for the audience to grasp. So I'm going to talk about human inflammation for a second, and I'm going to say something obvious to everyone. If you have no inflammation, you will have a very steady level of inflammation biomarkers because you don't have inflammation. The readings will be very stable. Whatever you want to measure, neutrophils, cytokine, very steady. If you have a human disease, it doesn't matter what it is, an inflammation disease, Crohn's disease, an arthritis, lupus, the inflammation that's present is not static. It goes up and down. Patients have flare-ups. They have circadian rhythms throughout the day. So here's the basic concept. Non-inflammation is stable. Inflammation is dynamic. That's the concept. So take that to eosinophils. There's a group of COPD patients who do not have eosinophilic inflammation. So I've published on this a number of times, looking in the blood, looking in the lungs. And at approximately, just approximately 100, their measurements are nearly always less than 100 or around 100. You never see them go to 200, 250. They never go up there. These people do not have eosinophilic inflammation. There's another group of patients who have eosinophilic inflammation. Some have a little, some have a lot. And their inflammation is dynamic, it fluctuates. So we have to get this basic concept because it answers your question. So then what you do is you just look at the pattern. Once you understand that, you can pick it out. You have one patient, their results are 80, 120, 70. You get the pattern. You say this is not eosinophilic inflammation. There's another patient who is 130, 250, 400, 180. that patient has eosinophilic inflammation.
That's the guy. Yes, fair enough. That's very, very nice. Thank you very much for this concept. The last question.
Sorry, could I just, so the reason I wanted to say that in a bit of detail is because I think clinicians worry too much about these strict thresholds. They think the eosinophils is like a cancer biomarker. So if you're using a biomarker for cancer, you want one threshold, and below no cancer, above cancer. Inflammation biomarkers are not like that. You have to look at the pattern. Sorry.
It's a spectrum.
Yeah.
And pattern. Thank you. The last question is a comment about this group of patients who had the ICS withdrawal during a trial, and people started arguing why that is. Why were people withdrawn from ICS? Were they developing side effects, complications? What was that about?
Sorry, unless I misunderstood. What I was saying was that many of the patients in real life were taking triple therapy.
Correct.
So then they entered the study, and some of them are randomized to dual bronchodilator.
Okay, those are the people who are withdrawn from the ICS. Perfect.
Yeah.
Because they could not tolerate this ICS, because that's an important message.
No, it wasn't that. So the debate has been that some people have said, well, triple therapy only works because you've only proved that the patients get worse because they were withdrawn from triple therapy. But that still proves triple therapy works because they got worse.
Yes, thank you. Thank you very much. Professor Singh, thank you very much for being with us today. And it's been a great pleasure to see you. And I hope to see you in many upcoming events. You take care.
Thank you. Great to see you again.
Thank you.